Hello and welcome to the Answers for Cancers podcast. I am your host, Anne-Marie Fay.
And I'm Michelle Matthews.
Together with some of Ireland's leading experts, we want to unravel what it truly means to have cancer.
From consultant diagnosis to treatment plans, from managing your symptoms to supports available, we have it covered. So whether you're a nurse working in oncology or have been personally affected by cancer, this podcast is for you. Mandy Leslie completed her master's degree in clinical embryology in 2006. And she began her career with Sydney IVF in Australia, which is a leading fertility clinic. She gained extensive experience in all aspects of embryology, and as a senior staff member excelled in training new members of the embryology team. She moved to Ireland to take a position as a deputy lab manager in the Marion Fertility Clinic in 2011, and she helped introduce new embryology techniques to the clinic over the next 6 years. Mandy joined Sims IVF Swords in 2016. And as an oncology cryopreservation program manager and senior embryologist, she has been an integral member of the team ever since. Her experience has been invaluable in training new staff and in sharing the oncology cryopreservation program with the wider medical community, including presentations at conferences, lectures to oncologist nurses, medical students and hospital staff. She loves speaking with patients, hearing their success stories, and is passionate about beautiful embryos and getting the best possible results for her patients. Today, Mandy speaks to us about the egg and sperm retrieval process for our oncology patients. She explains how the patient can be referred for this service and how it's important to discuss your options with your oncologist. We're very grateful to Mandy for taking the time to explain this process to our listeners, and we hope you find it as beneficial as we did. So good morning, Mandy. Thank you so much for meeting us here at Sims IVF Swords today to discuss fertility for our oncology patients. I was just saying to you before we began there, it's something that myself and Anne-Marie don't know a huge amount about, so I'm really excited to learn more. I suppose I'd just like to ask a little bit about you and how you came to be in this role.
Sure, yeah. Well, thanks very much for coming, and it's a pleasure to meet you ladies and help out any way that I can with this topic. So I started in embryology back in 2006. So I started in Australia, and I spent 4 years in a clinic in Australia, which was terrific. And then I was sort of looking further afield, and I came to Ireland after that to work at one of the other clinics over here. And I've been with Sims IVF in Swords since 2016. And sort of helping to manage the oncology program here. So, and it's just been a delight, really. Yeah,
fantastic. Brilliant. I suppose we'll start with just tipping off how oncology patients can be referred to the service. Who would be responsible for referring them to the service?
Sure. So any oncologist in Ireland can refer to our service. So it's patients diagnosed with any sort of cancer can be referred to us, but it has to be adult patients that should be referred here. We do have a dedicated oncology coordinator as well. So when the referrals come to us, the coordinator will organise all the appointments and make sure we've got all the blood tests results and get the patients in to see the clinicians as soon as they possibly can.
Perfect. And is there an optimal time for patients to be referred if, say, they've been diagnosed and there's a treatment plan kind of in progress?
I suppose the easy answer to that is as soon as possible. Yeah, so as soon as they possibly can. So we do need to see them before their treatment starts because the gonads, the ovaries and the testicles are very sensitive to chemotherapy and radiation. Now, some cytotoxic drugs can be more damaging than others, and obviously the radiation dose is dependent on the patient's age and the location of the radiation as well as the total dose. So it's all it's much better for us if we can see the patient as soon as possible.
Great.
Also in terms of like surgical interventions as well, we'd like to see the patients before there's any surgical intervention because it can be damaging to the patient's future fertility if the gonads are involved, or if surgery is even close to some of the important reproductive structures, so the fallopian tubes, the uterus, or even if the surgical site is close to the nerves that control erection, something like that.
Yeah.
So.
Okay. And how long does it normally take? So from when the consultant would refer them to you guys here, how long does it normally take for a patient to be seen?
Well, we know that it's obviously a time-sensitive issue, so we can get them in as soon as we possibly can. There's no waiting list for oncology patients, and we can usually see them within 48 hours.
Oh, wow.
So
that's amazing.
So the men can often be booked in to give their semen sample on the same day, as long as we have sort of all the blood test results and all the paperwork done. For the ladies, it is a little different. So when they come in, so within the 48 hours, we can usually see them. But the oncologist needs to give us 3 to 4 weeks clearance. so that these patients are able to wait 3 or 4 weeks before they can start their treatment. That's because it takes this long for the stimulation of the ovaries and that sort of thing for us to be able to do the fertility preservation and then release them back to their oncologist.
Okay.
It's important to say, I suppose, as well, that some patients are not suited to have fertility preservation. If the oncologist can't give us that clearance, or if they're not able to wait the 3 to 4 weeks, we are completely in agreement with the oncologist's decision. And we'll support them, and we'll support the patient in that decision as well. So we've got counselling services available that can sort of talk through all these sort of scenarios. We always defer to the oncologist's professional opinion. So we understand that, the saving the patient's life is more important than preserving their fertility.
Yeah.
So that's something we will defer to them.
Yeah. Something I always wondered was, I suppose, especially with the hormone positive breast cancer patients, because I presume, and I don't really know how it works, but you're giving them hormones, are you?
We are giving them hormones, yeah. So it needs to be managed really carefully for hormone positive patients. So we can actually do fertility preservation within a natural cycle. Now, the problem with that is you only would collect 1 or 2 eggs.
Yeah.
And to preserve fertility, we want to, obviously it's going to be a numbers game, so we want to get as many eggs as we possibly can. But yeah, if they get a referral here and it is a hormone positive cancer, it can be managed much more carefully.
And then going back to then the initial consultation that they have when they come to the clinic, what happens at that initial consultation, and would there be anything a person could do to prepare for the consultation?
Yeah, so they wouldn't need to be doing any preparation as such. So when they get to the appointment, they would meet with the clinician. So they would discuss their situation, they would sign an informed consent form. They'd usually meet with our oncology coordinator as well, so to organise some appointments, and sometimes they meet with the patient support services as well. So we've got a counsellor here. So the men would usually give us a single sample, and they can do that on the day as long as we've got the blood work back. The ladies can start on their hormone stimulation almost straight away. So we don't need to wait for their period. We can start them anywhere in their menstrual cycle. So they can start sort of within the next few days on their stimulation treatment. So after their appointment, the lab would phone the patient to give them the results of the sperm freeze, and then they can return to their oncologist and start their treatment. With the ladies, we have their hormone blood tests, and they would have a scan every couple of days to see how well their ovaries are responding to the treatments. And then the days would be followed by an egg collection. So within sort of 10 to 14 days of stimulation, and then it would be followed by an egg collection at the end of that. So, and the patients would, once they've had something frozen, they would keep the samples in liquid nitrogen for 5 to 10 years, and that would be free of charge. That's covered by the clinic as well. But we do request that they give us contact every year, just to make sure they haven't moved address or changed phone numbers or something like that.
And is it injections that the patient does at home? Is that how
it
the
is?
eggs are stimulated?
Yeah, it is. Yeah. So the injections that they're having are follicle stimulating hormone, which, like the name suggests, it stimulates the follicles to produce, stimulates the ovaries to produce more follicles, and that in turn produces more eggs.
Okay.
Yeah.
They're taught how to inject themselves.
Yeah.
But yeah, they do need to do that.
And it's
at
just
home.
subcut, is it, or
Subcut injection?
Subcut.
Yeah, subcut injection. Some patients would require IM progesterone, but very few patients would have that, and particularly like the oncology patients don't get any progesterone because they're not having an embryo transfer after it. So there's no need for progesterone treatment after the collection.
And then can you tell us a little bit about the male sperm preservation?
Sure. So the gentleman would provide us with a semen sample in a pot that we would give them. So once we get the sample back into the clinic, we would count the number of sperm. We would have a look at the motility of the sperm. So motility is how well it's moving. And we'd have a look at the morphology of the sperm. So how good they look, how nice the sperm look. So once we've assessed the initial sperm sample, then we would add a cryoprotectant to it. So that protects it from being damaged by the freezing techniques. And then so once we have done the initial assessment, we would usually freeze up to 8 straws. So the straws are little sort of plastic tubes that we would freeze single little samples in. So we would freeze up to 8 of those for a patient. We would always thaw one out. so they would always be left with 7. So the reason that we thaw one out is to make sure that the sperm have survived, so that we can give the patient an accurate determination of what treatment would be recommended for use with that sperm if they needed to come back and use it in the future.
And can they be frozen for the same amount of time as the egg? Like you said, 5 to 10 years, is that right?
The 5 to 10 years is as long as the clinic will fund the freezing. It can actually be frozen really indefinitely. We don't really know if there is a timeline on it, but we do know that it doesn't. It's not to the detriment of the sperm or the eggs or the embryos to keep them in storage. So they're frozen in liquid nitrogen. They don't deteriorate, and we can really keep them as long as the patients need them.
Okay, so it's really down to funding more so with the And then touching off funding, is there much cost involved in doing the egg and sperm retrieval?
So we get funding at SimSwords from the Department of Health. Now it's partially funded by the Department of Health. The majority of the cycles here are funded by SimSwords. So the sperm freeze is funded, the egg freeze is funded, the embryo freeze is funded. For all of our oncology patients, but the patient does need to pay for blood tests, and they will need to pay for any drugs, because these are billed from different companies. So the pharmacy would bill you for the drugs, and the blood test would be billed from another company. So we do provide the fertility preservation free of charge. So it's the preservation that we're funding. Now, if the patient does need to come back to use the material in the future, that is not funded. Okay.
Yeah. God, thanks for that, because I know, like, especially with oncology patients, you know, there can be a huge financial burden for people. So it's really good to know that they can come and have this option. At least they know in 5 years' time or 10 years' time, whenever, you know, that they might be in a better position to come back and do something with them.
And it's also, it's not a cost that they've expected. It's not like they've been able to save up for it. This is just, you know, throwing them for 6. It's just, you know, a diagnosis, a recent diagnosis, and they don't have, you know, any idea about all these costs involved. So yeah, it's all funded free of charge, but if they do need to come back and use it in the future, that will not be funded.
Okay. And then is there any benefits to, like, freezing eggs or embryos? Is there any one that's
it depends. It depends on the patient situation. So when we would talk about freezing eggs or freezing embryos, if the woman has a partner, she might choose to freeze her embryos because the survival rate and the pregnancy rate from frozen embryos is much better than eggs. But when embryos are created, then both partners would have the right to veto their use. So if the relationship breaks down, then one of the partners could say, no, you can't use that material, and then her fertility preservation, her potential, you know, pregnancy has been lost because someone has said, you know, you can't use the embryo. So the other option is egg freezing. So if the ladies are single, or if they're not in a long-term stable relationship, we would recommend freezing eggs just for that reason rather than freezing embryos.
Mandy, you mentioned before about there being counselling available for patients while they go through this process. Is that something that's just part of the service as well? Or?
It's part of the service, absolutely. So we have Helga, she's a specialist fertility counsellor, and she's got many years of experience doing this, you know, counselling for fertility patients as well as our oncology patients. So she's emotional support, she helps with decision making. So obviously these patients have just been diagnosed with cancer. There's difficult decisions to be made. There's, you know, do I go ahead with fertility preservation? Do I not? How is the diagnosis affecting them? How is their prognosis affecting them and their families? She can also talk about what if they're not suitable for fertility preservation and how to deal with that emotionally as well. So, you know, just to help them get through this procedure, get through this time in their lives, and then hopefully move forward after the treatment.
Really important service to avail of, I think, isn't it?
Very, very important. Like this.
And Mandy, what are the success rates of the egg and sperm retrieval or embryo formation?
In terms of pregnancy rates, so if we're talking about embryos, we're talking about pregnancy rates. So in terms of pregnancy rates for fertility preservation patients, the statistics are about the same as for generally infertility patients having embryos frozen. So for example, a lady who's under 35, she has one embryo transferred, the pregnancy rate is about 50-50. So the pregnancy rates will decrease as the lady's age increases, and that's the same for everybody. In terms of egg survival, the eggs are vitrified the clinic, and the survival rate for the vitrified eggs is very good. Now, the number of eggs that we collect doesn't translate into the number of embryos that would be available for use, and that's the same for oncology patients as well as infertility patients. But the eggs that we've had in the clinic that we have had patients come back for, that have thawed out and created embryos, we have had good success rates with those. So
Brilliant.
And is there many legal implications at all? I suppose one thing that we were discussing as a unit when we were coming here, we asked the girls that we work with, is there anything that we're missing? And we showed them the list of questions. And we were wondering, is there legal implications if somebody wanted to use an embryo or a sperm of somebody who had passed away?
So when the patients come in for their initial appointment, they sign an informed consent, and this covers posthumous use. Okay, so they can designate a named partner. So this partner, in the event of my death, may use my material. Or they can say, I don't wish anyone to be using my material after I pass away, if I do obviously pass away, and they can request it to be destroyed. So we would always go with, back to the original informed consent if patients or patients' partners are coming in saying, I'd like to use this material after my partner has passed away. So we would refer back to the initial consent. Have they consented for this to happen? Have they named this same partner? And if not, they can't be using it. So it's also helpful, I suppose, to ask the patients to put that in their will as well, so that their loved ones are clear on their wishes as well.
So is there a criteria that patients have to meet to be able to avail of the service here?
They have to be diagnosed with a cancer, so some sort of oncological condition. They have to have what we call EU bloods, so blood screening, so therefore contagious diseases such as HIV, hepatitis B and C, and CMV. So we have to have those screenings back. We have to have the results before we can store any material. So for the male patients, we should have those results back before the day of their semen freeze, and for the ladies, we would need to have them back before the day that they had their egg collection.
Okay, perfect.
So it can kind of be working away in the background.
Well, the lads, because they come in on the day to see the doctor and do their freeze, we need to have them before that. So it's important that the oncologist orders them, so that we're not sort of delayed in waiting for those screening tests.
Fair enough.
Okay, perfect. And is there anything that you would recommend patients consider when they're thinking about this? Just any kind of tips or?
I would recommend coming and talking to someone.
Okay.
So see if you're eligible. If I think you would always regret something you didn't do more than you would regret something that you did do. So even if you don't need it in the future, I think it's comforting to know that I've done my best, and this is
Had the conversation.
I've had the conversation, and I've stored my material, but in 5 or 10 years time, when I'm looking to have my family, whether I need to use it or not, that's for future times.
That's really good. That's really important.
And just to ask, so what happens exactly on the day of egg collection?
So the patients will come into the clinic in the morning. They will be taken to theatre. They're placed under a light sedation so that they're comfortable while we're collecting the eggs. So once we've collected the eggs, the embryologist will put them in a dish, put them into an incubator, and then if the patient's having an egg freeze, we would be freezing the mature eggs that we've collected that afternoon. And the patient would expect a call from the lab later that afternoon to let them know how many eggs we've been able to freeze. And if the patient's having an embryo freeze, we will also need obviously a sperm sample from her partner. And then the eggs can be inseminated later that day. So we would either mix the eggs and the sperm together and just let them fertilize themselves, or if the sperm sample is below average, we can inject a single sperm into each of the mature eggs to help them to fertilize. And then they would be left in the culture media overnight, and we check them the following morning. So the following morning we would be looking for fertilization, and then we would be looking for the presence of what we call pronuclei, and that just shows us that they're normally fertilized. And then after that they would be placed back in the incubator, and we have an embryoscope actually in the laboratory at the moment, which is an incubator that has a camera attached. So we're not disturbing the embryos. We're not taking the dish in and out of the incubator every day to have a look at it. We just put the dish in the morning, and the camera takes a picture every 20 minutes of these embryos in 7 different focal planes. And the software can put all the pictures together and create a video. So we can see these embryos dividing. We can see on day 2 that they divide into 2 cells, into 4 cells, into 8 cells on day 3, and they start to form a blastocyst structure on day 5, which is the structure that we're looking for when we're looking to freeze these embryos. So on day 5, we would freeze anything that's top quality or good quality. If we're not able to freeze something on day 5, we would look again day 6. So they do get 2 chances to be able to be frozen. And the afternoon of day 6, once we've completed all the assessments, then we will give the patient a call and tell them how many embryos or blastocysts they have in storage, and then they can go off and see their oncologist and hopefully get themselves sorted after that.
I imagine it's quite a nerve-wracking phone call to see.
It is sometimes. Yeah, it is sometimes. Sometimes they're brilliant.
Yeah.
Sometimes, you have a terrific result, and sometimes the results aren't what you're hoping for, what the patients are obviously hoping for, because they're putting so much stock in what we're doing here.
And they're under time constraint as well.
Under time pressure, and if they're having, if they haven't had the result that they wanted, it's very confronting. This is my future, and I'm not able to, have any sort of certainty over it. So
yeah,
but it's amazing that the service is here.
Absolutely,
it's terrific.
To give them the
terrific
option,
service to have.
Absolutely. Yeah.
So I mean, we can't guarantee being able to create pregnancies and be able to give these people children in the future, but we can preserve the possibility. I suppose.
Absolutely. Yeah.
Oh, Mandy, thank you so much. It's really, I think it's really nice to know, even for us now, by the time someone meets us and they're coming for their chemo, what they've gone through, even psychologically before, just to have some kind of idea what they've gone through by the time we've met them. So thank you so much. I really
My pleasure.
appreciate
Thank
that.
you so much.
I think it's definitely going to give people a bit of hope just to know that this is here. And like you said, even people down the country and stuff who don't necessarily know that it's here, if they're listening, they know that it's
absolutely.
And like you said, just opening the conversation. So
this is it. Come and have the conversation with us, and we'll see if we can help.
Great.
Brilliant.
Thank you so much.
Our pleasure. Thank you so much.
Thanks for listening to the Answers for Cancers podcast. Please share this podcast with anybody who you think it might help. Also, if you can like and subscribe, it lets people know we're here. You can alternatively contact us on Instagram at the Answers for Cancers _podcast. And if you've any questions on anything that we discussed today, please email us at the answersforcancerspodcast@gmail.com, or you can DM us on Instagram.